All this is Dr. Mubin Sayed from drbeen.com. Welcome to one more show. So, the RSV virus infections are increasing, have increased for pediatric patients, especially, and also for above 65 patients as well, especially those who have comorbidities or have immunocompromise. So then the question becomes, why is this happening? Because, for example, in the adults at this time, the rate of hospitalization is 10 times more than normal seasonal RSV infection outcomes. Still, it is, I think, about 6 out of 100,000. Per 100,000 of population, 6 people are ending up in the hospitals. It is 10 times more than normal. So there are discussions that is it because uh, kids are going to school and then they're picking it up from there? Is it because we are now mixing and mingling and going out, and that is the reason? Is it because we were in the lockdowns, and our immune system was more pristine, was naive about these infections, especially for the children? Was it because masking? So there are so many theories out there. And I have been discussing with Dr. Paul Marek. You may have seen FLCCC's discussion today about the management approaches for RSV and flu. So I would actually recommend that you please watch that for the management. I have been working with Dr. Paul Marek to put that protocol together. Lion's share of the work is by him. And then the question, why RSV becomes serious, why vaccines failed, and what is the underlying mechanism? This question has been explored since, I believe, 1960s. So it's an old question. However, in today's time, presence of COVID has potentially tipped the balance of RSV towards more severe form. So this is a hypothesis, and nobody is talking about it at all. Maybe they're not connecting those dots. For me, these dots were connected by Dr. Paul Marek. So credit once again to him. He brought it up and I said, all right, I'm going to look into this. And it was so exciting and interesting to look into that I've been calling him all day long, again and again, and saying, I found this and I found this. So let's share that with you as well. The summary of this is going to be that it is possible that SARS-CoV-2 is causing T helper 2 pathway or humoral pathway to be taken. And I'll show you the studies that say this. You may have remembered that I talked about a study where they said if SARS-CoV-2 in some people take T helper 1 pathway, and I'll explain those pathways in a second. Listen to the summary first. If it goes T helper 1 pathway, then the person becomes asymptomatic or have milder cases and don't even know that they had SARS-CoV-2. But if it takes T helper 2 pathway, the humoral pathway, the antibody production pathway, then people have more severity. This means, I'm still on the summary, this means in a patient's body, if they had exposure to SARS-CoV-2, their immune system has leaned towards T helper 2 pathway, and all cytokines related to T helper 2 pathway are present in the environment, in our body's environment. If you put RSV virus in that environment, then it is possible that the immune system response to RSV will also go T helper 2 pathway. And if that goes T helper 2 pathway, then the propensity to have severe disease is more common in humoral pathway responses compared to cytotoxic pathway responses. This is the summary. Now, what is the connection with vitamin C, D, and even vitamin A? That connection is vitamin C has been shown in many studies to help the immune system move more towards T helper 1 pathway. And there are tons of studies that say it does it. There are tons of studies that say it does not. So, without going into the um, back and forth of vitamin C's mechanism, there is a potential that vitamin C moves the immune system towards T helper 1. That means nowadays, especially those who are at risk and they may have been an exposure, they may have been exposed to SARS-CoV-2 and then maybe with RSV, vitamin C may be useful in them. On the other hand, vitamin D has a dose related propensity. That means the more dose you give, the more it does. And that propensity is to move towards T helper 2 pathway or humoral pathway. So, vitamin D prefers to create antibodies. Vitamin C prefers to have cytotoxic response. In case of viral infections, especially with the RSV, we will like cytotoxic response, and especially with RSV, we will not like antibody response because IgE, when produced antibody, can cause severe disease. I discussed that yesterday. And people who may not have asthma, IgE in them caused by RSV can cause asthma. And those who may have asthma, it can cause aggravation of asthma. So that is the role of vitamin C and D. That doesn't mean quit vitamin D, but large doses may not be um, suggestible at this time. So lesser vitamin D, but still ample to be able to have correct vitamin D balance, and more vitamin C. And finally, vitamin A. Vitamin A in normal, regular levels does not have much control over the T helper 1 or T helper 2 pathways. But larger doses of vitamin A. So, for example, if there are patients who are using vitamin A for their diseases and they're using larger doses, in them as well, T helper 2 pathway is selected. So, vitamin A will need to be calibrated as well. So, this is the basic discussion. Now, let me walk you through the mechanism and the studies related to this. So, because I use this OBS, I end up with this kind of a mechanism. So, let's start from the study here. So, starting from the references, this is drbeen.com. The link is in the description. This is only $67. I think this is a holiday gifts now. Only $67 one time fee to get access to more than 900 lectures on drbeen.com for medical concepts. This is one. Then this is a quick, the link is in the description. This is just a quick note for the 65 plus having 10 times more hospitalization. So if you read here, according to the CDC, about 6 out of every 100,000 adults have been hospitalized with the virus, a rate that is 10 times higher than for this time of the year. So I'm going to stop this because of the ads. Then look at this one. An early T helper 1 response is a key factor for favorable COVID-19 evolution. Look at the time, January 27, 2022. So it's a more recent study. What this study is saying is that COVID or SARS-CoV-2, if it is managed through T helper 1 pathway, and I'll explain the pathway, and majority of the cool beans who are here know these pathways because we're discussing them for 2.5 years. But anyways, for the new cool beans, I'll discuss that in a second. Let's look at the studies. So T helper 1 response is the key for better outcomes for SARS-CoV-2. However, we also know that SARS-CoV-2 actually moves towards T helper 2 pathway. Okay, so then next study. High dose vitamin C supplementation increases the T helper 1, T helper 2 cytokine secretion ratio, meaning it takes, when our body is responding to a virus or viri and bacteria, the T helper response pathways are taken more often compared to T helper 2. So the T helper 1 to T helper 2 ratio increases, that is, more T helper 1, but decreases eosinophilic infiltration in bronchoalveolar lavage, fluid of oval ovalbumin sensitized and challenged mice. So generally, T helper 1 pathway is favored and selected by high doses of vitamin C. Then the long history of vitamin C, from prevention to the common cold to potential aid in the treatment of COVID-19. This is 28 October 2020. I left this one in here for a balancing act, because what these authors did was they went through a lot of studies, and for every single aspect of vitamin C, what they did was they brought in the favoring studies and countering studies and put them all together to say, here is some studies that say it works, here are some studies that say it does not. So it is interesting if you're interested in vitamin C. But some things here that were interesting for me. It says reports underline that vitamin C can induce a shift of immune responses from T helper 2 to T helper 1. Now, please remember, T helper 1 pathway is very important for RSV. I did this discussion day before yesterday that RSV, especially when it is managed by our body through T helper 2 pathway, then our body will produce more IgE. Of course, it would produce IgM and then IgG and then IgE. The IgE part then primes the natural killer cells and the mast cells, and there is a hypersensitivity reaction that appears. And in smaller children, because the lungs and pathway airways are generally small, if you occlude them more, if you inflame them more, they would end up in a hospital. So vitamin C will help. Physiological levels of vitamin C are also necessary for normal natural killer cell development and function. In vitamin C deficient mice, natural killer cell cytotoxic activity was lower than that in mice with normal levels of vitamin C. Then, vitamin C also regulates inflammatory responses. In animal studies, vitamin C deficiency has been linked with higher circulating histamine levels, which can be rebalanced once vitamin C blood level has been normalized. This is very important. If less vitamin C results in more histamine, and then somebody has RSV, which causes more IgE production, if the T helper 2 pathway is taken, then that histamine, because of the mast cell, would also exacerbate. So as soon as you normalize the vitamin C, the histamine levels would start dropping, plus the humoral pathway will reduce, and cytotoxic pathway or T helper 1 pathway will become more prominent or dominant. Very important role. Then here, influence of vitamin C on lymphocyte, and here in this study as well, they discuss this. This is another study now for vitamin D3. Vitamin D3 inhibits the proliferation of T helper cells, downregulate CD4 T cell cytokines, and upregulate inhibitory markers. So if you see here, we observed that the stimulation of CD4 T cells, helper T cells, with vitamin D3 suppressed proliferation capacity, enhanced the expression of PD1, PDL1, CTLA4 inhibitory markers, and diminish the percentage of pro-inflammatory cytokines, and see which cytokines are reduced. Interferon gamma, that is a cytokine produced by T helper 1 cell. Interleukin 17, produced by CD4, and interleukin 22, except interleukin 4. Interleukin 4 is produced by T helper 2. So what they're saying over here is that when you give vitamin D3, it causes T helper 2 cell to continue to function normally or more, while T helper cells function is reduced. And how do they know? They see the cytokines produced by these cells. T helper 1 cytokines, interferon gamma, are reduced. T helper 2 cytokines or interleukin 4 production is increased. So that is an evidence to say that D3 promotes humoral pathway, and for RSV, we want the other pathway. Now, luckily, for COVID as well, we want T helper 1 pathway. So if both of them are present, it is better to have T helper 1 pathway. So similar intervention will help for both. Then if you see here, this is another vitamin D3 study. Treatment with 4,000 IU of vitamin D3 decreases intracellular CD4 ATP release. So here in this study, they use the ATP production, the energy production in helper cells after vitamin D3 to kind of assess their activity. And you can see in a proportional odds model, high dose vitamin D3 was more likely than low dose vitamin D3 to decrease CD4 ATP release. So that is the helper cell change. Then high level dietary vitamin A enhances T helper type 2 cytokine production. And I'll talk about that as well in a minute. But here the term T helper type 2 cytokine production and secretory immunoglobulin A response to influenza A virus infection in mice. So here, look at the high level. A high level vitamin A, 250,000 IU per kg diet or 75,000 retinol equivalents versus a control diet of 4,000 IU. So again, this is for those who are taking high-level vitamin A. In such patients, it is possible that T helper 2 pathway is taken more, and either they can reduce vitamin A or add vitamin C to kind of balance it out, especially during this season. Then a couple of more studies here, interleukin 10 and the interferon gamma. I left it for your review, but I would discuss that in my discussion. And then regulation of effector and memory T cell function with type 1 interferon. So now you have seen all these studies. Let's quickly go over the diagrams. Okay, so here are my diagrams. I have been drawing the cells more and more. So some of them are more polished and some are less. So the discussion is respiratory syncytial virus, interplay with COVID, role of C and D. We just discussed that. This is a study that I just showed you in the beginning, not a study, article, that even adults are getting sick and hospitalizing. Now, this is the diagram. Again, if you see this diagram, it seems a little polished in some areas and not polished in others because I've made some cells so far and I have not made others so far. So let's start from here. On this side, let me change my brush. So on this side, we have a macrophage or dendritic cell, left side of the diagram. This macrophage has captured a pathogen, maybe SARS-CoV-2 or maybe RSV or both. We know that it will present the antigen from this pathogen to T helper 0 cell or naive T cell. This is the acquired arm, and this is innate arm that contains other cells as well, which I have not made. So once the antigen is presented to T helper naive cell or 0 cell, then it depends if we have interleukin 4 in the environment, and this is very important to keep an eye on. The cytokines and interleukins are present in the environment, and their presence can switch every cell's function regardless of what pathogen is present. So here interleukin 4 will cause the T helper 0 to become T helper 2. T helper 2 will then present or secrete interleukin 4 and 5, interleukin 10, and many other. Here, interleukin 4 and 5 are important because they would cause the B cell to proliferate, differentiate, and then start making antibodies. Right? So class switching would occur as well. So what will happen is the B cells would start making IgM and then IgG and IgE and A and so on. The sequence is MDGA. M, then D, then G, then E, then A. The summary of this is that it is possible that some pathogens would cause humoral response. When humoral response is occurring, we can check if that response is occurring by seeing a quantity, by measuring the quantities of IL-4, 5, and IL-10. Now, IL-10, when released from T helper 2, in turn causes a suppression of the macrophages, and it also suppresses the T helper 1 pathway. So, what happens is, whichever pathway is selected, that pathway tries to suppress the other pathway. But here is an important thing to note. This is the only delicate point in this whole discussion. That point is this: imagine there are two pathogens. Let's say SARS-CoV-2 and RSV are present together. Imagine that RSV will have actually gone this route of T helper 1 pathway. But presence of SARS-CoV-2 caused the humoral pathway. When the humoral pathway is taken by SARS-CoV-2, there is interleukin 4, 5, interleukin 10 present in the environment. Now, if you inject RSV in this person, or if that person is exposed and catches RSV, even if his body or her body was going to go to the T helper 1 pathway, because of SARS-CoV-2's presence and these interleukins' presence, the T helper 1 pathway is suppressed and T helper 2 pathway is selected or enabled or facilitated. So because of these interleukin, even the RSV would have a greater chance to be responded by T helper 2 pathway. That has in turn the possibility of a more severe disease from RSV compared to T helper 1 pathway. This is a very important point. So if somebody had the infection with SARS-CoV-2 or has the infection with SARS-CoV-2, and their cytokines are present for T helper 2 pathway, then they are exposed to RSV, or if they're exposed together, their chances of becoming severe can increase. This is a point that so many doctors at this time and researchers are missing. We are looking at this community, medical community, we are looking at masks and pandemics and the lockdowns and opening up of the community, going and meeting in the schools and all that. We are looking at that. But there is a molecular or cellular level mechanism at play as well. Now, if imagine there was no SARS-CoV-2 present in the system and there was RSV, then RSV will go this pathway. In most people, we still end up with some severe cases, but that is a small percentage, 5% of the children, for example. So what happens is, normally when RSV arrives, our innate arm cells would pick it up, they will present it to naive T cell. Naive T cell would then go T helper 1 pathway in the presence of interleukin 12. Interleukin 12 is secreted by the macrophages and dendritic cells, and they would make the naive cell go T helper 1 pathway. T helper 1 pathway would then, the T helper 1 cell would cause that would release interleukin 2, that would activate the cytotoxic T cell. And check out my cytotoxic T cell, it's a new version. I still have to polish this. The cytotoxic T cell has perforines, these hammers, or I should have made them like knives, that would perforate the cells. And look at this cute little Grim Reaper looking like a cat. It's for Luffy. This is the granzyme. Granzymes are the enzymes that would enter the cells that have gotten perforated by the perforins and then go in and activate the caspases and ubiquitins and cause the cell to die. So this is the cellular cytotoxicity. This is killing of a cell by the cytotoxic T cells that is preferred for viral infections, because virus is hiding inside the cells, and killing that cell is the right way to remove the viruses. So this pathway is actually useful. What can stop from this pathway? Vitamin D3 will suppress this pathway. Vitamin C will actually enable this pathway. Vitamin A in high doses will also suppress T helper 1 pathway. Then SARS-CoV-2's presence or previous exposure, but recent, not last year exposure, previous exposure can cause this pathway suppression as well. Now T helper 1 cell, when becomes active, it releases interleukin 2 and it releases interferon gamma. Interferon gamma in turn enables the innate arm. It enables the macrophages and natural killer cells and others. And activated macrophages then release interleukin 18, and interferon gamma also in turn suppresses the T helper 1 pathway, sorry, T helper 2 pathway. So whichever pathway is selected, it tries to suppress the other pathway so that this pathway can get all the resources and do its function. And why am I talking about these cytokines? Because when you would read those studies, the researchers, when they're trying to figure out which pathway is taken, they measure these cytokines, and based on that, they know which pathway is working or is dominant. And they found out, let me show you a study. So if you see this one, in this study, it says type 1 and type 2 cytokine imbalance in acute respiratory syncytial virus bronchiolitis. Here, in this green part, type 1 cytokine, let me see if I can make it a little bigger. So in the green part, if you read, they say type 1 cytokines such as interferon. So type 1 T helper 1 pathway. Interferon gamma, remember it released the interferon gamma to go and activate the macrophages and natural killer cells. Interferon gamma produced by type 1 effector T cells, interleukin 12 from antigen presenting cells, that was the macrophage itself, and interleukin 18, that was the activated macrophage. These three, interferon gamma, interleukin 12, interleukin 18, are a proof that T helper 1 pathway is working. So then they say promote cell mediated immunity and are required for effective response to intracellular pathogen, including viruses. Type 2 cytokines, such as interleukin 4 and 5, remember from T helper 2 pathway, and interleukin 2, which is also from T helper 2, all produced by T2 cells mediate allergic responses. Why allergic responses? Because number one, they would cause antibody production, and number two, IgE would then go and prime the mast cells, and that would produce allergies. So here in this study, they looked at RSV, and they saw that those children that had severe outcome, their T helper 2 pathway were selected. This part is I'm showing here. And those children who had a milder case with RSV, their T helper 1 pathway was selected. So again, a very important thing to keep in mind. Okay, back here. So after this, mast cell, I just discussed this, that if T helper 2 pathway is taken, IgEs are produced, then these IgEs will cause a priming of the mast cell. That priming in turn would cause mast cell degranulation and histamine production. That would cause severe disease, bronchiolitis. That would not alone, but overall inflammatory response will cause bronchiolitis plus airway obstruction plus asthma-like syndrome. And if asthma was already present, then exacerbation of asthma. If asthma was not present, then creation of asthma. And then finally, we discuss this T helper 2 pathway selection versus 1. So this is the discussion. Thank you very much for watching. I want to see this question. So Stefan says, This study is talking about ADE with RSV as T helper 2 pathway will be activated if body had prior exposure to RSV. They confirmed that in rats, and we know it happens with the RSV experimental vaccine. Yes, this is actually, I discussed that a couple of days ago. The vaccine, especially for the RSV, failed because of the ADE that occurred because of the humoral pathway, and now they're trying to make other vaccines. One more thing that is important to understand that it failed. They said that that vaccine was not neutralizing, it was binding. So it actually ended up causing ADE. And 80% of the vaccinated individual children who also got RSV breakthrough infection, they ended up in a hospital, and two died as well. Compared to naturally infected children, only 5% of them ended up in the hospital. So, of course, vaccine had the role, and they agreed and they stopped. So, this is the discussion. Let's see, there are a couple of questions and we stop. Would Wordsworth says, what about interleukin 4 blockers, such as, yes. So, interleukin 4 blockers will help. Anything that would improve interferon gamma or reduce interleukin 4 will help. But at the same time, we have to be sure that we do not just totally suppress this, because there is a possibility of need for that as well. But yes, RSV would require or need T helper 1 pathway to be taken. Now, please also remember, if RSV is managed by IgGs, then there is not much problem. For example, IgG from mother actually is protective. Similarly, IgG monoclonal antibodies are also protective. It is the natural response to RSV through T helper 2 pathway where class switching occurs, where we go from M and D and G and E. That is where the problem occurs. So if there were monoclonal IgGs, that are protective. If there is mother's IgGs, these are protective. But if the child's own or the person's own system goes through the whole uh, change, then that is where danger is. So, John, without showing your question here, yes, I think that in their discussion, the document that I reviewed, that had the thing that you're talking about. And one more request. The discussion day before yesterday with RSV, people came in and said, well, it is pointless discussion if you don't talk about vaccination status. This has nothing to do with the vaccination. Not everything is about vaccines. We are talking about RSV, we are talking about molecular mechanisms, we are talking about COVID interaction, vitamin C, vitamin D, vitamin A interactions. Why do we have to inject vaccine everywhere? So Tamara says, can vaccine inactivate the T helper 1 pathway, putting us at a disadvantage? So there are some vaccines that try to prefer T helper 2 pathways. But for example, Johnson and Johnson had in their document, in their manuscript, that Johnson and Johnson has, I believe, interferon gamma like molecules in their adjuvant that prefer T helper 1 pathway. But all vaccines have some T helper 2 and T helper 1. Now, which one has which more? I would suspect that majority of the vaccines are trying to create antibodies, so they are going to propel the system towards T helper 2. But that will be when the vaccines were present. That could be 2 weeks or so. It is not forever. The system is not switched to T helper 2 forever. It will be there for some time. So that means if somebody got vaccinated today and the vaccine's adjuvant pushed them towards T helper 2, and then they became infected with RSV, then there is a possibility that RSV will be handled with T helper 2, which can cause severe outcome. Similar to COVID infection, which would also push towards T helper 2 and cause RSV severe infection. Thank you, Ramnik, and you yourself are a doctor, so Thank you for your comment. So Kim says, how much vitamin D? Vitamin C. I would suspect that a little more than normal. I am not big proponent of high dose in general. The reason for that is that everyone's body is different. So you have to talk with your doctor, figure out what is right for you. For example, if you are an athlete or uber exercising person, you actually need generally more vitamin C compared to others. So I would say at least more than the regular, but you can sit down with your doctor. So Michael says that excess vitamin A can be toxic. Yeah, many things can be toxic in excess. However, here we are talking about vitamin A to be less, because more vitamin A can take T helper 2 pathway. Nikki says if vaccines are really reducing people's immune system, then it is in fact relevant. So no, they're not reducing people's immune systems. This is just a strange concept that has taken hold. So M. Gregory says, what about vitamin C infusion? So yes, many doctors actually use vitamin C IV. So again, the point of logistics is different. I wanted to present the molecular mechanisms to understand the interaction of various viruses at this time and the importance of T helper 1 pathway. Whichever way that pathway is taken, vaccine caused it, T helper 2, then vaccine will have a problem. COVID caused it, then that will have a problem. You're taking high dose vitamin A for some disease, then that can cause a problem. So that is what I want to bring home, not sit here and talk about vaccines at this time. Okay, cool. So this is a discussion. Please like, subscribe, and share. Denise, this is also very important that it is a mast cell stabilizer, and that is how histamine levels are reduced. Vitamin C reduces histamine levels in two ways. One is directly stabilizing the mast cell, and secondly, reducing the IgE levels, because it takes the pathway towards T helper 1 cytotoxic pathway and reduces the humoral pathway, which causes less connection of IgEs to the mast cells, and so less degranulation as well. So yes, you're correct. Pierre says, Pieta says, thank you. So thank you very much as well. So please like, subscribe, and share. And there are some links in the description if you would like to support this work. A great thank you to Margaret. She sent in a big donation today. Thank you very much for that. And there are links in the description if you would like to buy me a coffee or PayPal or Substack or become part of Dr. Bean YouTube channel or purchase Dr. Bean account as well, which is at a very low price. So with this, thank you very much. I would see you tomorrow. Bye bye for now. And the smallest thing, you can like, subscribe, and share. Bye.